So I think given the task to talk about oromandibular dystonia, I bring greetings from Vedanta. These are my disclaimers. So what can go wrong, like Professor Dresser was showing a diagram, that what can go wrong with neck? It can bend forward, go backward, tilt sideways, rotate. Similarly, oromandibular joint does not have too much of mobility. So it can either open, it can close, it can deviate the jaw, it can protrude, and it can retract. These are the only limited movement which can happen to jaw. So these are some of the muscles, and the most common muscle we know that we need to involve. If it is a jaw opening dystonia, then bilateral lateral pterygoid. We'll talk about various lateral pterygoid and how to do that. These are classic muscles, but also additionally, these are some of the patients when you have been injecting for 5-10 years. So these muscles get atrophy. Then secondary muscles, which are anterior diagnostic muscle, platysma, agenioglossus, that take over and give dystonia, may not respond to the primary muscles. So this is the time when you inject secondary muscles. What my rule is, I always inject only primary muscle to begin with. If it does not respond, I give you a classic example. There was a professor of IIT and he said he can't talk now. He had severe jaw opening dystonia, and he has stopped taking lecture for last 2 years because he cannot take a lecture. So whenever he talk, he can't talk. So I injected first time. How was the effect? No effect. I injected second time. How was the effect? No effect. He is disheartened and I am also disheartened. That was my beginning of career. But then I told him, this time I am going to inject a double dose. You may have problem. You may have dysphagia. If you respond, then you come. If you don't respond, find a better man. So with a great heart, injecting a double dose, you are scared, and I was a young faculty. I injected him high dose, and he responded marvelously. And that taught me that if you are not responding, it does not mean you are wrong. The wrong thing could be the muscle may not be adequate. He has severe jaw opening dystonia. And other thing I have noticed, if you have a severe disease, if you inject little larger dose, the response will come one thing, and over the period of time they respond very well. I injected him for 2 years, maybe 5-6 settings, and after that he stopped coming. So I knew he doesn't have it anymore. Otherwise he would come, otherwise he will not be good. And when the last time I met him, he said, now I can talk for 2 hours non-stop. So that was the change. So if you have jaw deviation, then contralateral lateral pterygoid is the primary muscle, but ipsilateral posterior temporalis and platysma can also be playing. Jaw protrusion, bilateral lateral pterygoid. Now let's learn the anatomy. I've been told that I have to finish fast. So we'll just look at the muscle. The lateral pterygoid, as you can see, this has a 2 head, upper head and a lower head. And I can stop this from where it's originating, where it's going, because we need to learn how do we inject the muscle. Then what is the action? If the bilateral lateral pterygoids are acting, lower the mandible soil, jaw opening. With bilateral lateral pterygoid and bilateral medial pterygoid, it protrudes. So 4 muscles are acting. Bilateral lateral pterygoid and bilateral medial pterygoid acting alternatively. So normally, do we do this? Yes, chewing. When you are chewing, both the muscles are acting, but usually you don't see this in dystonia. Medial pterygoid. So as you could see, the medial pterygoid is this muscle. It again has 2 layers. The upper one was lateral pterygoid. So when they act bilateral medial pterygoid, it elevates the mandible. When the bilateral lateral pterygoid, with bilateral pterygoid, I think we talked about it, it will protrude. With ipsilateral lateral pterygoid, and so one side medial pterygoid, one side lateral pterygoid, it will rotate towards forward and towards opposite side. This movement. So it's acting both sides. With bilateral lateral and medial, I think we already talked about this side to side movement. Masseter. Masseter is a very superficial muscle, and though it comes into 3 layers, the biggest layer is the outermost layer, which is just under the skin, and the biggest muscle. So you can, I always put my finger like this, ask him to cleanse the jaw, feel the muscle and get a shape of the muscle. Where is the muscle? And I usually avoid clenched muscle. You know why? It's more painful. So you feel the muscle, you know where you have to inject. I usually make a space between the finger and inject 2 points. If you use hypodermic needle, which is about 1 centimeter needle, even if you go full deep, it will be in the muscle. Because about half of the needle will be in the skin because that thick is this here. I think we talked about it. Temporalis. Temporalis is a big muscle, which is a fan-shaped muscle. So if you put your hand just above the diabetic charge and you feel this, and you will feel the anatomy of the muscle. If you know this is the muscle, you can inject 2 or 3 points. Let's see some of the videos. So this is the patient. I hope it works. So sit the jaw, you opening this one. Is sound coming? Sit again. Because I am going to ask you a question here. Is there a doubt in the opening? No doubt? But is there a lingual dystonia also? Commonly, patients who have jaw opening or oromandibular dystonia, they may have associated lingual dystonia. You know? Now, how would you know this is a jaw opening dystonia or lingual dystonia? How do you differentiate? Looking at the patient? No. Listen to them. Now, listen how I speak. When I open my mouth, how I am speaking? Taking the voice when you open the mouth. Okay? So you hear the quality of the voice. But when you have lingual dystonia, classically jaw tongue protruding. So I will protrude my tongue or try to bring my tongue forward and speak. When I am trying to speak, I speak like this. Is there a difference in the quality? So when you listen, you know which muscle is prominent here. When I am trying to speak, I am speaking like this. So I am opening the jaw, but lingual is also coming. When I am also doing like this, it is more hollow. So if you listen to the quality of the voice, you know which muscle is also involved. Rather than when you look at it, jaw is opening and tongue is also coming out. But then you don't know which muscle is active. So we discuss bilateral, lateral pterygoid we can inject, and entry value of diagnostic. Dr. Vijay has demonstrated beautifully. So let's look at how to inject it. Before I show you the video, let's get it conceptually right. So feel the diaphragmatic arch. Could you feel it? Just below, clench your teeth and put your finger just below this. And now you relax. You feel there is a space. Just enter through the condyle of the mandible. You feel there is a hollow space. That's the space which you need to negotiate. So what I do, I put my finger anterior to the condyle and ask him to clench the jaw. When you clench, I know the space is gone. And when I relax, the space is gone. So I ask him to open the mouth a little. That's good enough. Okay? Now, I say always perpendicular to it, but I say go little forward, little downward. So it is about 20 degrees posteriorly, 20 degrees downward. So then you will hit the muscle from here to the little big muscle of the. Now look at the video. You saw that? When you open the mouth, the bust has become more. Sometimes even if you open this much, the jaw muscle is already contracting. When if you right in the muscle, you will hear the sound. Again, always get tuned to the EMG sound. Then you know this is dystonic muscle and not the, sometimes nearly in the masseter. And you think you are in the lateral pterygoid. So this is the patient whom we saw just now. After receiving Botox, she is so wonderful. So if you inject I used to inject very high dose to her. This is very clear. Jaw closing is very simple. Okay? But again, this is another disorder. A lot of patients with jaw opening dystonia will come like this. They have tried to speak like this. Because they have jaw opening. I said, don't clinch. Talk normally. When they talk normally, then they open their mouth and speak. So this is another way like cervical dystonia. There may be a false localizer or the compulsory movement. So if you ask them to thoda sa muh khol ke bolo, Now he is not clinching the jaw, then you open the mouth. So here, listen to her. So she's telling you when I talk, my jaw is clenching. So again, listen to the sound. When I speak, I sound talk like this. When I'm speaking, this is my normal way. When I clench my jaw, it still becomes like this. So if you tune you listen to the voice, you know that another which condition you can diagnose when you're sitting outside. Anybody? Listening to the sound. Sorry? Learning which one? Spasmodic dysphonia, yes. What else? Spasmodic dysphonia if you speak, then only. Which other condition? Sorry? Adductor? Abductor? Abductor leading to what dysphonia? See, larynx has two functions. One is speaking, second is breathing. So speaking, you can either have an adductor or abductor or mixed type. In speaking, what happens? When you normally speak, if you look at the vocal cord, they open. But there is a condition called adductor laryngeal breathing dystonia. Normally, when I'm talking, I breathe in between. Do you hear my voice? No. But if my vocal cord doesn't open well in time to breathe, so when I'm talking, suddenly, I'll do this. Now, when I do this, you have seen many patients. When they're talking, in between they do, so there is a stridor. The vocal cord doesn't open in time. I seen on video laryngoscope. So my ENT guy told me, see, normally when you try to speak, the vocal cord immediately open. Here they are adducted for some time and then they open. So if these guys sitting outside the OPD, you hear the sound. He's doing it every 10 seconds. So you know he has come. So I know which patient has come. So this is another condition. Here primarily you inject bilateral masseter. But if they don't respond, or if you think it is very severe, then you inject temporalis muscle. I think these are, I usually inject 2 points in masseter, half the dose. I start from 20 to 25 and go up to 40 or 50 units on one side if it is very severe. What is the other indication of masseter injection? Any other condition? Somebody showed the video today. Yes. They respond very well. Recently, I had a patient who also had digastric spasm. So I've been injecting, I have some 20, 30 odd patients. So we published this also. So we used to inject around 30, 40. I inject a little more because otherwise they come every 3 months. He also said there is a stretch here. So I injected digastric also. So here it's very evident. So it's lateral. So FC lateral. Medial terminal, contralateral, lateral trigoid. So I think I have a slide for medial pterygoid. Please look at the anatomy of the medial pterygoid. This is a coronal section. This is mandible. The muscle is going like this from here to the base of the skull. So how do you feel? Go at the end of the mandible, about 1 centimeter anterior, direct on needle lateral outward, and put your needle and ask him to deviate the jaw. You will hear the sound. Then you can inject. This is just to demonstrate how the jaw protrusion takes place. So you see this? Intermittently he is protruding his jaw. Thank you.